All right, and it is 10:25 on the dot, and so we will go ahead and get started. My name is Danielle Lauder, and I'm the Program Director for the Northeast Telehealth Resource Center, and I am fortunate enough to be the moderator here for this session with Lisa. Lisa Blanchard is the Vice President of Clinical Services at Spectrum Health Systems. She's based out of Massachusetts, and I had an opportunity to be part of a Project Echo with her a few weeks back and was just so very impressed with how quickly they stood up telehealth for their behavioral health and substance use disorder telehealth program, which she's going to share with you today, and the very practical way in which she shared the information. So I would like to welcome Lisa, and as mentioned earlier, we're going to keep these bios extremely short because we want to give all the time to our wonderful speakers to share their expertise and what they've learned. And so I'm going to go ahead and turn it over to Lisa now. Thank you so much for everyone for joining us, and thank you, Lisa, for sharing your time with us today.
All right. Thank you so much for having me. This is something that I've been very excited about at Spectrum and for the field in general. So I'm really excited to be able to kind of share how we as an organization quickly pivoted to adjust all of our services to meet kind of a more mobile need so that we can continue to treat really the most vulnerable in our population despite the pandemic. As you can see here, I'm going to talk a bit about behavioral health, substance use disorder, how we as an organization implemented telehealth, and then some time about practice considerations, things to consider in the behavioral health realm. So the objectives of the presentation is obviously to learn how we did that, including, there's a bit on billing and coding, but really more process information, identify kind of approaches to care. So how do you continue to provide both inpatient and outpatient care, including consent and safety planning, the differences between telephonic and video telehealth, and innovative ways to really adjust your workflows to meet patient needs. Because certainly, although we're certainly moving towards different phases depending on the state that you're in, depending on the community you're in, there is definitely kind of some long-term impact that we're going to feel related to this pandemic. So just quickly, just so you know who we are, so that helps you understand kind of where we're coming from. Spectrum is, a large behavioral health organization. We're a nonprofit. We just celebrated our 50th anniversary, this past year. We're in several states, although predominantly most of the community-based treatment is in Massachusetts. Most of our work in other states is in correctional institutions. And we also provide some Department of Youth Services adolescent treatment. And so the services that we provide, and you'll hear me talk a bit about today, are our inpatient services. We've got 2 campuses that offer acute detoxification and clinical stabilization, as well as shorter and longer term residential treatment. Our outpatient services, where we have 14 locations spread throughout Massachusetts that are predominantly medication-assisted treatment, medications for opiate use disorder, providing methadone, and in many programs also providing buprenorphine and providing naltrexone. We do have a program that's a kind of more rapid access, kind of hub and spoke model for buprenorphine. And we do outpatient counseling, intensive outpatient, as well as some peer recovery support centers. And as I mentioned before, the correctional and adolescent treatment. So as you can see, we are a large organization, but we really hadn't gone down the path of telehealth prior to kind of this immediate need. We had been talking about it. I think the state of Massachusetts had been talking about it for a long time without a lot of movement in the direction of providing telehealth specific to behavioral health. But then, of course, COVID hit, and we had to immediately move all of our counseling sessions to a telehealth model, right? So in an outpatient setting, we have, over 5,500 clients across the state that are in active treatment in outpatient alone. And we had to move all of those services, which were, predominantly traditionally, in person, lots of group counseling sessions, lots of individual counseling sessions, very much needed supports for medication-assisted treatment to a telehealth model. So key to that was the fact that Massachusetts Medicaid payers and commercial payers and Medicare responded quicker than, honestly, I think I've ever seen them respond before, to allow coding and for telehealth sessions. And this was extremely important because they allowed both telephonic and video. Because certainly, especially in substance use treatment, the population that we serve may not, have what I have in front of me, right? Like a laptop with Wi-Fi, with all of the things that you need to do kind of video sessions, and or may not just have the capacity to management. And we'll talk a little bit about that today. And so that has been very important, the allowance for both telephonic and video sessions, so that we can stay connected to the individuals who may be, at home during treatment. And also, both federal and state Massachusetts regulations were adjusted to allow take-home medication for methadone. And so if you're unfamiliar with how methadone treatment works, we're actually probably the most highly regulated service for substance use disorder, maybe for any service, honestly. It typically requires, face-to-face nurse visually dispensed medication every single day. And so that system does not lend itself well to social distancing, to, having, less individuals in a program. We have one outpatient program with over 1,500 clients in it. And so that makes it very challenging to keep people both safe from COVID, but also safe from overdose and from relapse related to their opiate use disorder. So those changes to both the federal and state regulations were extremely important. So we were able to provide more take-home medication than we normally would. And also Suboxone providers at buprenorphine have more flexibility for telehealth and prescribing practices. And so what we did very quickly is choose a platform. And so we chose Doxy.me, as a lot of providers have, and a lot of folks may have heard of that, for all clinicians and prescribers. And we actually secured accounts across all of those 14 outpatient sites with, many, many counselors, many prescribers, within 1 week. And we notified our clients immediately. And so I think that notification piece was really important because in order to have people connect to you via telehealth, you have to let them know it's available, and that's how we're going to support you. So for those folks on methadone in our opiate treatment program, we gave letters, kind of classic, they're coming to get their medication or their take-home medication, depending on whether they were eligible for the expanded take-home access, saying, here are all the ways in which we can support you. You should receive a notice from your counselor, and we'll do telehealth sessions. But we also use a text message alert system, especially in our opiate treatment programs, because sometimes things happen. Power goes out, that means longer lines at the program, or if there's severe weather and we have to make changes to scheduling. We already use a text message system to do that well. And so we put a blast kind of text message out to everybody about our telehealth implementation. And we also, like many practices, both medical and behavioral health, utilize kind of a reminder call system that's tied to our appointment scheduler in our electronic health record. And so we embedded messaging to that reminder call system to let people know that, we'll be scheduling this session. Don't come into the building, right? We're going to do this session remotely. So, because communication is certainly key. And so we started with individual counseling because that was a little bit easier to implement, right? Each individual counselor with a client whom they have rapport with, trying to navigate this process via either telephonic or video. But after about a month of doing individual sessions with telehealth and learning the platforms a bit, we started piloting both telephonic and now video group sessions. And so, group counseling is really one of the most effective treatments for substance use disorder, right? Because it's able to provide both, practical skills that you can practice in the group setting, but also support from peers and support from a clinician in one session, right? So it's also really efficient, right? You can treat 10 people in one group session versus one person in a 1-hour counseling session. And we started with some of our court-mandated clients because there's certainly higher motivation to complete things that are mandated by the court. So that includes some of our other outpatient services like first offender driver alcohol education and batter intervention. And then we added the opiate treatment program groups. And so we started those groups with kind of a later phase. So individuals who have been in the program for a long time and had kind of a cohesive group that they had been meeting with regularly. Because honestly, we were getting requests from our clients to say, I'm really missing this group connection, right? I think we all are missing group connection in some way, shape, or form right now, but especially those, either in early recovery or long-term recovery, really kind of need, that connection. And so we added those groups in kind of just to see how it went. And we started telephonically and then started adding in video capacity for those that could. So it could be a bit of a blended group with some individuals on the phone and some individuals on video if they had the capacity or the desire to do so. This is just a quick note on the coding. And so, like I mentioned before, we were able to kind of be paid the exact same amount we would do, in person, but do it remotely, which was extremely important for us as a nonprofit organization. But these are all the behavioral health codes, both counseling, group counseling, physician visits, mid-level practitioner visits for prescribing that we were able to just kind of add telehealth component to. How that's done is a little bit different by payer. So some required a GT modifier or replace a service code. And some of the challenges that we actually have found, because we are so spread across the state of Massachusetts and New England and New York in that area does definitely have crossover. We have outpatient programs in border communities. And one of the challenges that we have found, if somebody was quarantining across the border for whatever reason, even if they were a Mass resident with Mass insurance or whatever that might be, there were limitations for us to be able to do telehealth if they weren't physically in Massachusetts. And so, I'm hopeful that some of the feedback that we've given to payers that we could make some changes because sometimes people for safety had to be, just across the border. So for example, one of our outpatient programs is in Haverhill, Massachusetts, and we're literally on the border of New Hampshire. Like you can across the parking lot from our outpatient program is New Hampshire. So certainly we've got kind of a mixed population there. I'm going to shift gears a little bit to talk about what we did in our inpatient program. So, as a reminder, we do offer a detoxification, clinical stabilization, which is either a step down from detoxification or a stabilization bed if somebody doesn't meet detox criteria, either because of their use patterns or because of the substance of choice, if it's, a stimulant or an amphetamine or cocaine or things like that don't have a detox protocol, as well as longer-term residential. And that's a real challenge. Like, how do you, just like some of the things we've seen in concerns with nursing homes, how do you keep everyone safe, but still give them the care that they so very much need and the stability they need right now? It's a congregate care setting. It's not set up like a hospital in substance use inpatient care where, you've got really separate rooms, separate bathrooms where you could manage isolation very differently. We have shared rooms, shared bathrooms, shared common spaces, not a lot of common spaces. And that's typical for a lot of inpatient substance use treatment. And so we had to kind of really step back and be like, all right, what can we do here? So we continued group counseling, and we do so with masks and safety, but we did that with reduced group sizes and increased frequency so that we can keep that social distancing, possible as much as we can. And so that required us to maybe multiple smaller groups throughout the day, move groups outside. And so, fortunately we're entering this kind of, improved weather situation. And so we really have done a lot of both group and individual sessions outside, right? So that using kind of outdoor recreation areas, and we're fortunate, especially at our larger campus, that we have a lot of recreation areas, and in our program in Weymouth, Massachusetts, we don't have a lot, so we've had to be extremely creative. One of the other things that Spectrum did immediately, and I think we were the first one in Massachusetts to do so, is recognize the need for individuals who test positive for COVID-19 who also need inpatient substance use treatment. And then what do? We can't certainly bring people to hospitals that are bogged down, as we know, in general because of the pandemic. So if somebody is not in need of acute hospital care for their COVID-19, then we really don't have a place to put them. So what we did as an organization is isolate one of our units in our Westboro campus with the support of the Department of Public Health and the Bureau of Substance Addiction Services, and created a cohorted, isolated unit that we could do both withdrawal management, detoxification, and clinical stabilization, whatever your needs were. And so you had to test positive, and you had to be able to be safely maintained without, a lot of additional medical care. And so what we had to do that's really cool with telehealth is we gave each patient a tablet. And so they're in their room, they're isolated, and they have a tablet by which they're going to do all of their clinical services and clinical resources. And so we set up that doxy.me so that I could have a clinician in another building and the client in their room and conduct a session, right? Conduct an assessment, conduct regular sessions. And we also uploaded clinical materials to those tablets. And so that could be kind of adjusted group material that's similar to what you'd get in a group session, but formatted in such a way that it's consumable by the individual. And we were very fortunate, because of the breadth of services that Spectrum provides, we had to do a lot of that reformatting of group material in our correctional institutions for a very similar tablet program, where individuals who are in kind of secure units or in what you might know as solitary confinement are required to receive similar services. And so we had already done a lot of the work to shift our clinical materials to something that could be directly read by the individual and followed along versus taught in an individual or a group session. And we also put links and access to online self-help. And you may have heard kind of a lot of we're online now, right? This would have been in person. It's now virtual. Everything had to go virtual. And that includes a lot of the very needed recovery supports of either 12-step or self-help meetings like Smart Recovery, Refuge Recovery, and others. But they all had to quickly go virtual. Even cohesive groups that regularly met every Tuesday at 12 in the church basement went virtual, like a Zoom, for their own session. And so we gave the individuals in that COVID unit access to those online resources. And so that's kind of how we quickly just turned on a dime and implemented all of these things to continue to support the really vulnerable populations that we do. So now I want to shift gears a little bit to kind of what are the things that you have to consider and that we had to quickly consider and send out to our clinical teams to prepare for providing more telehealth sessions, right? Typically, behavioral health, and there's been some online increase over time, but, the more traditional behavioral health and especially substance use counseling has been in a very boundaried setting, right? In the office with the clinicians in their office. There's no kind of, self-disclosure. There's no the ability to see what is in their space. It's a very controlled environment to, clinicians being at home and having to do telehealth sessions. Like you can see, I could blur my background, all of that. But I just don't like how the visuals look sometimes when I present. It kind of loses me in the video if I do that. So, you're actually seeing my living room behind me, right? There's some kind of self-disclosure there that I'm not usually prepared to share with clients that I treat. And so you have to ensure a private location. So if this is my living room, this would not be an ideal telehealth location for a session. Fine for a virtual training. So ideally a home office or a room with a door. Sometimes the challenge with that is, and it's the same in my own home, the only rooms with doors are bedrooms. And so that's a lot of self-disclosure and a lot of boundaries that you have to be careful of. And so setting up space is important, right? Clinicians should not see patients from their bed or vice versa. And you might need to do some psychoeducation to your clients on why that might not be ideal. Consider having a noise reduction or a white noise machine. So often like what you'll see that's either now built into ceilings or in little noise machines throughout an outpatient practice or a medical office. You may need to have something. You can also, there's all kinds of apps, right? Like you could ask Alexa to play white noise. There's lots of ways that we can do this now, and there's a lot of sleep apps and mindfulness and meditation apps that kind of have some background white noise that people can use, so that it kind of drowns out things that are just life, right? Like, I had to just, place my dog outside so that hopefully the mailman does not arrive in the middle of this presentation, and those things happen. But paying attention to what can be seen in the camera view. So what I was just talking about, having that background be neutral. If you can't have the background be neutral, consider a room divider or a screen or using settings on the platform that you're using to create a neutral background. And the other thing I encourage people to really think about, because especially in behavioral health, but really in any setting, we often are careful about self-disclosure, and we might not have a ton of pictures of our family, of our children, of our partners, throughout our office, because that leads to a lot of questions that may cross some professional boundaries. But when there's telehealth and you're seeing into my space, if I have a wall, turning off television, drink some water, muting phones, moving pets outside like I just did, dress appropriate for the session. I think we all are in this place that we dress differently than we used to because we're home all the time, but we should still have some business casual attire, right? We should still consider that. And then even things like using headphones with a microphone. So that helps with clear audio as well as protecting privacy, because sometimes it's unintended, right? You have a secure space, but children don't necessarily pay attention to those boundaries, or even teenagers and things, and you want people to feel safe. So that's kind of setting up the environment. But then there's also some process issues to consider when you're doing a telehealth session. And so, in advance of the clinical session, schedule them. Certainly there's a lot of capacity when there's no shows to embed telehealth, to try to reach out to folks who maybe missed their last session or you haven't talked to in a while. And that's perfectly fine. But for most sessions, it's really helpful to have that scheduled in advance, right? So you have the time and space that you need both for yourself and for the client. So it mimics that kind of scheduled office-based setting, where the client and you or the patient, well, I'll use those interchangeably, know they're coming into session so that they know that they have their issues to bring up and you have your agenda. It does make that easier, even if it's done in a remote fashion. Test out technology. It might not go perfect, right? Like it's quite possible, despite me having shut off all of the Wi-Fi in the universe, including, thermostats and my robot vacuum, that I could have a connectivity issue, because that's the reality of Wi-Fi right now, right? You've got to test it and then give some time for it and have patience for when it does not go perfectly. You need to still get consent, right? Consent for that telehealth session. And so the way that you protect yourself and your organization and the patient is to document that you did that. The other piece is to really verify the identity and location of the patient. Sometimes, either it's because it's a new admission or there have been staffing challenges related to COVID or not, you may be seeing someone that you don't know very well, or you've never met. And so you have to really be sure that you're documenting that this is who you're supposed to be doing the session with, right? We're billing their insurance. We need to do something to be sure about that, but also the location, and document it. And we'll talk a little bit about that. And so, you want to kind of get a sense of where they're at. Are you at home? What is the location? What's the address? Is there potential for confidentiality or disruption, and how do we plan for that so that everybody feels safe? So part of the reason why you want to get that telephone number and address is so you can reconnect. If it gets dropped, how do we connect if we lose connection today? And how do we manage it if there's any safety concerns that come up? So, those are things that happen really to any practitioners, but especially in behavioral health, and especially with everybody being in such a vulnerable state right now, that there could be something that comes up that you want to address, and you need to know their address if something were to happen. And so planning that in advance, and remind clients about what other safety options are out there, whether that's mobile crisis teams, emergency departments, especially where we're not seeing people directly as frequently. The other thing, especially in behavioral health, that I think you have to address directly is boundaries. There's inherent boundaries, like I mentioned. When you're sitting in an office and I've got my name tag on, and what my role is, and then there's just an inherent kind of shift of boundaries when we're both at home. And so you have to remind patients about that you have the same boundaries, right? That my role is still as your counselor, as your therapist, as your clinician, and that's what we're going to focus our time on. And so, reminding about those boundaries. And it's also okay to normalize how challenging this is, right? The shift to telehealth is not necessarily natural for everybody. There's going to be varying degrees of comfortability. It's new for the clinician, so that makes it even harder, right? We all had to learn at the same time how to do this. And it's okay. It's okay to joke about it. It's okay to kind of, be like, isn't this weird? It's so weird. I'm so glad I get to see you face to face. Or if you couldn't and you had to do telephonic, this is so strange for me trying to help you and trying to conduct a session just on the phone. But we're going to do our best to get through it, because I'm here to support you today. And there's certainly some benefits, and I've had some clinicians in my program speak very eloquently about kind of the added benefits, though, of seeing a patient in their space, right? When they come to us, we only know what they bring to us. We only know what they say. We only know what they describe. And sometimes seeing somebody in their home environment, things that in-home therapists have probably known for a very long time, but those of us that are in office-based settings are just learning, is that, you can really gather a lot from somebody's environment, and what they're dealing with or not dealing with. And it's okay to talk about those things. Like, I noticed this, but you have to be careful about not appearing judgmental, as we all should, but kind of saying more about, tell me more about what I'm seeing in your background. Tell me more about, what kind of space you have here, and who else has to share that space, or anything else that you see that's concerning. Although the requirements may be during COVID, a little less stringent from regulatory requirements on, you got to get that treatment plan done, you got to get that outcome measure done. Sometimes what we've found is using those really valuable kind of clinical required documentation tools can help structure the session. So, when you're setting an agenda with someone you're meeting with, and we're going to go over your treatment plan today, that can really help, especially as we all get used to doing this in this format, structuring the session and having a full session instead of feeling like you're running out. And so, I want to shift just a bit to not just the considerations and setup and how you might go about, approaching behavioral health via telehealth, but kind of some of the things that because we implemented it so quickly, that we had to learn from very quickly. And so one of those things is, clients that weren't engaging face-to-face before. And that's an unfortunate but common, challenge for those in substance use treatment. They don't always make it in the door when you want. They don't always do all the counseling and all the sessions. And sometimes that's just barriers that are completely out of their control, have actually found it easier. And so that there's some real positive benefits to this. So for example, we run an outpatient program in North Adams, Massachusetts, which is up in the Berkshires and is much more rural than a lot of our other communities. And transportation is a real challenge. And then you add in all the other challenges around, childcare, work, all the other co-occurring medical and behavioral health concerns that make it hard for somebody to get into the office, even if they very much want to or need it. And so being able to do it from where they're at, we've actually had better engagement with some folks that we had a hard time getting in the office before. So there's some real positives there. We've also found that some patients have felt more comfortable opening up in virtual sessions, that they just kind of feel more comfortable than kind of coming into a clinical office and talking about their concerns or their challenges, that they feel more comfortable in their own space to do that. So they're leading to some really positive clinical sessions. And when we are able to do the video chat, like I mentioned before, it really does give us insight into clients' living space. Right, so it allows clients to share personal items they wouldn't normally share, coping skills that they have or use, things that they can really speak to what they're going to do in their own space at the end of the session, which sometimes that knowledge is hard to transfer to real life. So there was a great example. I don't remember if it's in these slides, so I'll skip it if it is when I get there, so I'm not repetitive. But I had a great example when I asked for feedback from my teams on how this telehealth is going. That one of our clinicians said they had this long-term client they'd been working with for years who was very much interested in art, and that was on their treatment plan to do more artwork and build that into their recovery plan. And that video session actually allowed them to go to look at the art and really feel like how important that was to their recovery. And it really was a very powerful session that you wouldn't have necessarily been able to do without being able to provide the session in their own space. But there's lots of, challenging lessons learned too, so, not all of the existing equipment that our counselors had allowed for video sessions, right? So if you're at a desktop computer with no camera and no speaker, this is not going to work for video sessions, right? So, and of course, we were not the only provider looking to add cameras and laptops and equipment to our practice when COVID hit, right? We were competing with every single industry, not just healthcare, which certainly made it more challenging. And although, the telephonic sessions were easy to implement, it was a lot harder. And so, we definitely found that, it's more work on the clinician's part to create the scene and to conduct the session when it's telephonic. In fact, clinicians have reported that they feel absolutely exhausted at the end of the day doing telephonic sessions. And so, other lessons learned, although it's not possible for all clients, if you use that video, it reduces that cognitive load for the clinician and can improve engagement, right? So where you can see me talking now, it feels more natural than if you were just looking at my slides and you couldn't see me. So the same goes for any telehealth session, but it's challenging to use a system that we are all learning at the same time. And so with assessments, though, we actually ended up creating a lot of printed versions and cheat sheets. So especially in our inpatient settings, when we were doing clinical sessions, we could, have kind of a cheat sheet for all the thousands of questions we were going to ask you in your full biopsychosocial assessment, and they could pre-complete them. It would make that process a little easier. But some of the feedback we got is it's super easy and helpful, to create that social distancing in inpatient, and the clients really seem to appreciate to be able to see who they're talking to, right? Especially inpatient, where that's a shorter term acute setting, like you may not have that rapport built with the clinician. So doing it on the telephone is going to feel very strange. In an outpatient, if there is a no-show or somebody's unreachable, you can kind of go through the rest of your caseload and be like, who have I not connected with? Who am I worried about? And just call and reach people in a different way versus waiting for them to present to us. And as I mentioned before, the later phase, more cohesive groups responded better to telehealth. And it's been a little more challenging with kind of early phase treatment groups that don't have that cohesiveness. So I'm just going to shift to spending just a couple of minutes talking about substance use treatment considerations in this kind of remote setting. We can't do the typical monitoring that we would normally do. It's definitely, toxicology screening at regular intervals. It's not how we make clinical decisions, but it's information that's helpful to us. But that doesn't lend itself to a lot of social distancing and reduced contact. So we've had to really increase clinical contact, using video whenever we can so that we can put eyes on people, especially when they're getting more take-home medication than they normally would, which even if you're in long-term recovery can be triggering for individuals to maybe not take it as prescribed. But also, especially the social isolation is very, very challenging for everybody, right? Like we're all feeling a little anxious, we're all feeling a little off and not sure what's going to happen in the future, but those in recovery, it's really challenging, right? So that connectedness is extremely important. Substance use, thrives in isolation, and recovery thrives in connectedness. And so we have to create that connectedness in a different way now. But it's also dangerous to be isolated. And so you can see my graphic, and that's the use of Narcan to reduce opiate overdose. The likelihood that somebody is either going to relapse is higher, but that the likelihood that they may be alone because of social distancing and social isolation, or that they're hiding kind of use from family members that they're quarantined with, can certainly increase the risk of overdose. So the things we need to have open conversations about are access to Narcan in the house. How do you know if you are going to use, let's talk about ways to have you not, but if that's going to happen, who are you going to tell you are? Who's going to know that you are so that we know if something goes wrong? And so just, a couple of quotes from clients, some people love telehealth, it certainly helps those with agoraphobia. I mentioned that artwork case, so I did have that on my slides, so I won't say it again. That people love kind of not having to come to the program. That transportation, especially if they travel far, really can be a barrier. The video sessions are preferred over the phone by many people, but some, don't have the capacity or are resistant to video as well. And a lot of gratitude for conducting groups because they've missed everyone. And although it's strange, it's great to have support. So one, I really liked this one. It's nice to see her clinician's face. It felt very comforting. I think we forget how comforting we can be for individuals. It's nice to have normalcy. It's challenging, but I understand. I've missed everyone. And so a lot of gratitude for how quickly we implemented telehealth. And then, of course, there's challenges. So, some people just don't have the technology. Ooh. Sorry, some people just don't have the technology. They either can't navigate it or don't want to, or won't even try to figure it out. And some clients, and even some of my clinicians, if I'm being honest, are not comfortable with seeing themselves on camera. And that's been a barrier as well. And then there's privacy concerns, and some kind of negative, feedback too. But, we're doing the best we can. And so now I think we're at the point of kind of, asking some questions and question and answers, and I'm happy to take any questions from folks. So
Fantastic. Thank you so much, Lisa. You can all see why we wanted to have her come and share what they've learned, and just a phenomenal program. And we thank you again so very much. We do have some questions that were submitted on the Q&A. So if that sounds okay, I'll go ahead and we'll get started with those. And then afterward, maybe Jason can unmute folks and they can feel free to ask questions. You can raise your hands, etc. So the first question is, do you have any plans in place yet for when we shift to predominantly mixed remote and in-person services in regard to incorporating that decision into the treatment plan with the client?
Yes, that is a conversation we're having with everyone right now. Like, at what point do we do more in person? For whom do we do more in person? And and how do we stage that? And so, we are doing some in person already. Our opiate treatment program specifically do walk-in admissions, and there is still the regulatory requirement that the physician needs to see the individual in person. That cannot be telehealth. So we've built a lot of systems around masks and distancing and spreading out that would allow that. And so how we're looking at it now, as we kind of wait for guidance from the state, because that's guiding kind of the direction that we'll go, is even now we could pull someone in for a face-to-face visit. And so we're doing it with kind of, a risk profile. Who are we worried about? Who do we want to put eyes on? Who are we concerned about relapse, concerned about their behavioral health concerns, their medical concerns, and using that as our guide to how we blend in person versus, virtual visits. And so that's kind of where we're at now.
Excellent. Thank you. Good question. Do you need to have consent for every telehealth session, or does a blanket consent suffice for a series of sessions?
So, I think you can get consent for the fact that telehealth is happening now, but you do want to document that you had that conversation in each session, right? It doesn't have to be long and drawn out, each time. Like, you can set up your consent for conducting telehealth in general, and especially where this is kind of how we've been doing it for a while, right? So we kind of did that initial kind of consent and notification, like, this is how we do groups, this is how we do sessions, but then kind of a reminder. And so one of the places we've had to do a lot of consent reminders is in group sessions, because there's a lot of challenges around, trust that the entire group is keeping privacy and confidentiality and using a safe space. So we've kind of reconsented that process in every group session.
That's a great point with group sessions. And just as a reminder, guys, remember, follow the standard. That's what it's all about with telehealth. If it's a standard for you to do consents more regularly versus annually for a lot of types of visits, then make sure that you're doing that. If it's, quarterly or whatever, make sure if you're doing it in person, try to do it via telehealth too, because it's really all about that, maintaining that standard of care. Awesome.
And document it.
Yes. Awesome. So one more question, and then we'll go to, we have some folks with hands raised. Are you using remote patient or home monitoring for OUD, SUD treatment, or post-treatment early recovery compliance and recovery behavioral modification support? For example, chronic disease self-management support. So remote patient monitoring or home monitoring.
So we're not using any kind of formal monitoring. I know that there's some practices in the country that are doing kind of remote toxicology screening, because that's really the predominant monitoring that we do in substance use treatment, right? Is that, we would normally have people come into the office and we do either an oral swab or a urine, toxicology screen and use that as information for monitoring on how people are doing. We haven't done kind of at home monitoring in that way. We've partnered with medical because we do, work as part of a care team. And so if there's concurrent medical concerns, we'll support that. So if they have kind of chronic disease management, things that they're monitoring, we'll connect and see how that's going. But we have not kind of done any kind of at home monitoring related to their substance use disorder.
Great. Patty, I think I did this right. I pushed allow for you to talk, so I'm hoping that you can now unmute and ask your question, Patty. There she is. And I'm asking to unmute you, so.
Is it working?
It is.
Okay, yeah. Thank you. I'm in West Virginia, and first of all, I'm very impressed with this as a wonderful session, and you all have just organized it. It's seamless. It's just so easy to use. I've done a lot of these over the last months. I've been board certified in telemental health since 2014 and have been offering it to my clients, and probably 50% of my private practice is addiction. I find it to be working out fine, and even though we've been slammed into it, I'm happy to be involved and to be able to continue to see my clients. I'm a seasoned counselor. I really am happy that we've been able to continue services. My concern is there are really lots of issues with people who have really are not using proper equipment. I had a lady that I talked with yesterday who's a school teacher, and she actually said to me, I hadn't seen her since COVID all began, because she was waiting and was willing to, come back to live sessions. And she said, "Oh my goodness, I don't want to use Zoom." She said, "I had my Zoom was hacked, and I mean, it was pornographic and crazy stuff that happened as a school teacher." And I explained to her the HIPAA compliance with the platform that I currently use and how I've had it for years, and it is very encrypted. And I said, technology can be flawed, and we can have that happen. But bottom line is, I'm concerned that moving forward, so much of what's been out there may continue, and it really is going to kind of muddy the waters for those of us that are doing telehealth and trying to do it appropriately. Just informational. I don't know that there's any response that you can provide for that, but I'm hoping that we're going to see it be a little better moving forward as we get back to the next normal.
Yeah, I would absolutely agree with that. And that's something that Spectrum, when we decided to respond immediately, because we had to, right? And Massachusetts was not as far along, as you were with telehealth at all. So it was kind of like a no telehealth to like all telehealth. And because of that, there was a lot of flexibility built in, and we chose not to take that flexibility, right? We're not going to use non-HIPAA compliant platforms. We're not going to FaceTime. We're not going to do these models that, have that level of inherent risk. I mean, think about how traumatizing that would be in a session with somebody who likely has trauma in their background, right? And they're trying to have a safe space. And so absolutely, I agree with you. And I'm hoping that, as we move past the crisis part of this, that telehealth is here to stay, in states like Massachusetts that hadn't really adopted it. But that's where all of the requirements are going to be enforced, right? So we started the process with, let's start telehealth quickly, but in a way that's sustainable, in a way that, as this, crisis and pandemic, shifts, and payers say you can still continue telehealth in this way, we'll be set up to do so. And that is with, HIPAA compliant platforms. And, I did a ton of guidances to all of our clinical teams on how to do this and how to structure the session and how to kind of manage and document those privacy concerns. So that, that's how we started it versus just kind of doing it however. And there is an argument to do it however, because so many people are at risk. I mean, I'll be, honest and say that, we've certainly seen, relapse in patients with long-term sustained recovery. I mean, years of long-term sustained recovery with negative outcome. And that's scary for everyone. And that kind of could lend you to just like connect however you can. But we're trying to kind of a balance of that, right? Instead of just kind of adopting, platforms that, kind of may be challenging, or may not be as secure or, appropriate.
Thank you. I'm also hoping that we can have more of a voice and lobby for, adequate and appropriate reimbursements, because I think this is going to be, we have a fine line here, and a lot of people are going to look at this as we move forward to determine whether or not they're going to keep these services in place. Many people do have issues with access to care. I'm in a very, very rural state, and it's very helpful to many, and there's still ways, checks and balances to keep people with substance use disorders compliant and still provide them good services. Absolutely. I think. Mm-hmm. Yeah. Thank you.
Thank you.
Absolutely. And the more of these success stories, agreed completely, Patty, that we can share data, certainly if you have it, to drive, preservation of the policy expansions during this time. It's been unprecedented. Certainly the telehealth resource centers have received hundreds of technical assistance requests, and we're subsequently seeing lots and lots of telehealth utilization, which has been amazing. But share those success stories and that data. So another question for you, Lisa: what are the key features or enhancements to telehealth platforms that you think will help in making such visits more useful moving forward?
I think just building on the challenges that we've seen, right? And some of them are things that I don't know if we can fix, right? Some of it is like just the Wi-Fi. If it drops out in the middle of a group session, Like that's hard. That'd be the equivalent of like the group session just stopping in time and in the middle of having some good momentum. And that's exactly what happens, right? That's what we've seen happen, with video especially, but even telephonic, like things just drop calls. Like there's some infrastructure challenges. And so I think, really we need to look at that infrastructure in general to mitigate that. And I think we need to challenge the platforms to help with that. I think some of the things we've seen, and at least based on what my IT team is telling me, I'm not an IT person at all, right? I'm a licensed mental health counselor, is that it doesn't matter which platform, the HIPAA compliant, all that you choose, the issues are the issues. And they all were slammed with this immediate need to launch into telehealth and to launch into telemeetings, regardless of what the business is, and they've all been stretched, So I'm hoping that going forward, the infrastructure that either the platforms need and that the systems need will be there, and even just ease of use, right? I find Doxy pretty easy to use, but you have to kind of send your own link. Like even if there's just workflow opportunities to simplify that for individuals that are going to have difficulty.
So this is the 3-part question, so I'll kind of go one by one for you. Any issue in lower capability to detect if a client on drug or alcohol for session for AA or NA? So that's the first part of the question. Is it harder to detect that?
Whether they're actively using while they're in session or in a meeting?
That's what they mean.
Yeah, and please feel free to chat in again if I'm not answering that, or if you have another way to ask it. The reality is it's not great, right? And not that it's even perfect in person, detecting impairment. Like we all get very used to it and very comfortable with it, because we've been doing this for so long. But recognizing it with somebody in telehealth is going to be very different. You could still recognize it, and then what do you do about it? So even preparing yourself for the reality of you may have a scheduled session with somebody who may be impaired. How are you going to address that? Just similarly how you would prepare yourself to address that, say in a group session, but it happens. It's just the nature of the chronic disease model that we're all working in, and that not everybody in your group is gonna be in the same spot. And so you have kind of ways you manage it in person in a group setting. How are you going to manage it if it comes up in a telehealth model? And telephonically, you could have some people just aren't going to engage as much, so you might not even know, there's no great way. So what we've been really stressing is, video whenever possible. We still do some toxicology screening, just less frequent, to reduce the face-to-face visits, but we are still doing it. And really just kind of doing what we can to check in and monitor in the best way that we can.
Mm-hmm. Okay, so second part of the question, can you talk a little bit about the need for the physical admission? How do you address that via telehealth if they need to be admitted physically?
So the service that we have the most challenge with that, because I had mentioned that buprenorphine had some flexibility that was not there before, where you could do that remotely. And so we have done telehealth sessions with the physician and able to prescribe buprenorphine, but we don't have the flexibility to do that for methadone. So just like in a lot of arenas, that kind of requires a physical assessment. And so what we've done is really mitigate those workflows, and that the only person who comes in direct contact with the patient is the physician, and that's with a mask, with PPE, with all of the protections that you would have in any medical hospital setting. We've had to outfit our behavioral health providers with, which they normally don't have to, right? Like this PPE is a thing that we haven't had to talk a lot about in behavioral health, and now it's something we talk about all the time, and have had to spend a lot of time procuring.
Good. And so the final part of the question, do you achieve e-consulting with providers in inpatient and or residential settings if Massachusetts policy permits that? So have you been using e-consults for?
So we haven't, we've been doing it ourselves like we would in person, but just using the, electronic platforms, that we have available and using kind of the telehealth model, but still having that access to our own providers. I do think that this kind of switch to telehealth will help with a lot of things around bridging people and consulting when you need to. So we are fortunate in that we have embedded psychiatry in our inpatient programs that we bill separately outpatient. And so we've been using a telehealth model to do that, but they're our own staff. So I guess in that way, we are kind of doing a more electronic consulting, but we already were doing that in person and we're just doing it with telehealth now. But in some ways, it's actually gotten easier, and easier to fill the prescriber's time. So for example, one of our psychiatrists in our outpatient site, our show rates are okay, but they're not great. And, that's just the population we work with. For the first time ever, had absolutely no-shows in one of his sessions. I'm not saying that's every day all the time, but in one of his sessions, he saw everybody on the schedule for the day, which, we thought was pretty awesome.
Absolutely. Great. Thank you. So we have another question in the chat. Have you been able to incorporate Hep C screening and treatment at your locations? And if yes, have you treated Hep C over telemedicine?
So we don't, we're not licensed to treat Hep C, but we are required regulatory to screen for it. And so that's one of the admission kind of physical requirements that we do. We are released from having to do it annually. And so that they'll certainly, this hasn't been going on for as long, but we do initial lab work in phlebotomy when individuals are admitted, and that includes Hep C screening. So then we refer out to to their primary care, to their health center, or if they don't have one, we connect them to a health center for the health Hep C treatment.
Gotcha. And there are certainly models that use telemedicine for Hep C. If folks want to know more about that, or we can pull together some studies, peer-reviewed research. If you're interested, just give us a shout. I think our emails are on all of our contacts on the app, so reach out to us and we can help you out with that. So I think that is the end of the written questions, either in the chat or on the Q&A on the app. I don't know, Jason, if we are able to make everybody able to talk at the same time, or if folks have questions, they can raise their hand and I can go in, or Jason can go in and unmute you or allow you to talk. If we have just about 4 minutes left, so we're open for additional questions.
I think you may have to do the unmuting as far as questions go.
Okay, so folks, it looks like we do have wonderful session. I agree, Patty. She says this method of offering counseling is more exhausting and not nearly as much fun, but we continue to support our clients and provide good service to folks who otherwise would be unsupported. Thanks for that feedback.
Absolutely.
Yeah. Anybody else that would like me to unmute you and you can ask a question? You can also ask it in the chat. I'm keeping track on the app as well. All right. So I think, can you advance to the next slide, Lisa?
Absolutely.
Perfect. Thank you so much. So as mentioned earlier, guys, this is our first virtual conference ever, and we would so appreciate you going, and this is right in the app, the Event Mobi app, at the bottom of each session. We would just ask you to take just a couple of seconds. We kept this as short and sweet as possible. If you wouldn't mind going in and giving us your feedback on the session, we would really like to hear from you on how this applies to and will work for you moving forward, and how we can continue to improve our virtual sessions moving forward. So thank you very much in advance for doing this. And I think there's another slide, Lisa. Just the thank you. Thank you to each and every one of you who joined us here today. We very much appreciate, we know that everybody has busy schedules, and we appreciate you being here with us, and we appreciate your feedback and your questions. And a huge, huge thank you to Lisa for sharing your time and expertise with us here today. We know you're exceptionally busy as well. And we really look forward to continuing to work with you and seeing your program grow. And thank you very much.
Yeah, happy to do it.
Have a great day, everybody, and we'll see you on the next session.
All right.
Bye.
Bye, everyone.